welcome back to Talking Ears. This is a bonus episode. I am in the office hours today with two of my great friends, co-host of Talking Ears, Juan Vasquez. How are you doing tonight?
Great, Frank. How are you?
I am great. We're also joined by our friend and friend of the show, Brendan Fitzgerald.
Thanks so much for having me, guys.
Thank you for being here. I'm super excited that you were able to join to talk about an important clarification of a recent episode. So we just released Vincent Karamanov's episode where he talks about his own ears and his own journey with hyperacusis. During that episode, Juan and I had the instinct of interrupting constantly. In fact, I actually did during the recording, interrupted him constantly. So you won't hear that in the actual episode. What you'll hear is Vincent telling his story. He was saying things like he has hyperacusis and he was hearing distortions in his ear. I really wanted to jump in and clarify the different types of hyperacusis and decreased sound tolerance. But I think that's actually better left for a side episode such as this. So that is why Brendan and Juan are here, to help us unravel this little puzzle box of hearing health science. So why don't we actually start with Brendan? There's a big umbrella term for hyperacusis and these other related conditions, which is decreased sound tolerance. Could you help us kind of unpack that a little bit?
Yeah. So to me, when we start thinking about things like hyperacusis, misophonia, even tinnitus can kind of live adjacent to this because it's sort of an aversion to sounds that are either perceived in the world or happening kind of between the ears as our brain processes sound. So this umbrella term of decreased sound tolerance just generally refers to all the kind of different flavors of the ways that our brain and our emotions react and respond to sounds that it's perceiving as negative.
Right.
Or
Negative
sounds that we have aversion to, right?
Yeah.
So generally speaking, I feel like this term is very helpful because it helps patients understand that there's lots and lots of variations on this theme, and that theme is decreased sound tolerance.
Yeah. And I remember when we had this conversation with Vincent, Juan, you probably remember this too, I stepped in and explained decreased sound tolerance as this kind of overarching term, umbrella term, and he had this response to say.
Yeah, that resonates with me a lot. Kind of the way it sounds is less maybe less alarming or something.
Yeah, it's more neutral sounding, isn't it? Decreased sound tolerance versus you have this thing that's clearly like a Latin word.
Right. Yeah.
Yeah, a medical problem that maybe he's referencing is like that, oh, you have this problem with your ears. My understanding and approach to managing all these oftentimes with patients is that this is more than just how sound is hitting your ears. That's an important component to a lot of these decreased sound tolerances. But again, kind of the theme here being, well, what does our brain do with it, and how do we feel about the sounds as they're coming to our brain?
That's something I come across a lot with folks who I see. Not all the time do I see patients or folks coming in with very severe tinnitus or decreased sound tolerance. It's more in the conversation, in the, I don't want to say interview, but in the dissecting, in the midst of talking about what's actually happening. It's actually more what they're referring to is how they're reacting and responding to the sound, not actually the sound itself.
It's always about the reaction, right? It's like it's with tinnitus, with hyperacusis, it's very much about what is your reaction to this?
I think that's a huge piece that oftentimes is not always visible with this invisible thing actually happening.
Well, to your point, Juan, right? Like many of the tools that we use to measure these difficult things talk about impact on quality of life. Few of them, again, we keep talking about tinnitus because it's kind of the most studied thing of a sound that's not well tolerated is ringing in the ears. But when we look across a lot of the things that we use to measure tinnitus, most of those questions are like, how is it impacting your function, like your sleep or your anxiety or your sense of control of your symptoms? And rarely is like, what's your perceived decibel loudness of, this particular extra sound, or where does this other frequency lie when you hear your diplacousis, or, so I think it's really important that when we talk about measuring these things, it's oftentimes about those emotional impacts.
Mm-hmm. And it's a good point too. Those tools that you're talking about, they're mostly questionnaires. So I've heard from patients before, they'll say, oh, I went to 3 or 4 different doctors. They didn't actually test me. They just gave me a bunch of paperwork. And I have to clarify, well, that paperwork is trying to get to the bottom of something that we can't take a picture of how you feel about your ears, right? You have to tell us. It has to be a subjective response on a questionnaire. So these tools are very helpful, and we use these tools to look at how you're doing today, but also how things have changed or progressed in the future with different treatments.
Yeah, that's a great point. And these tools are like really new too. Like the ones that we use for tinnitus, which is again kind of the most studied within all of our lifetimes, have been developed. So, we still look for good tools. Like I'm constantly looking for good hyperacusis questionnaires and other kind of like decreased sound tolerance kind of questionnaires, but they don't always accurately measure the impact too, or kind of the quality. So, again, we're kind of talking about like, well, how do we diagnose all these different conditions, right?
Yeah. And I think the last thing I want to say about the questionnaire tools is that people's personalities and just their outlook in that moment drastically change what they put down on that questionnaire. For instance, I hear from patients all the time, I didn't want to complain, or I didn't want to raise a stink on the questionnaire, or maybe I underestimated or overestimated. Can I see that back? Can I change it? So it's tough when we're dealing with subjective readouts. We don't have any objective way to read how somebody is feeling about this.
Yeah, good point.
I totally get it. It's in that moment, how are they actually feeling? Sometimes there can be a limitation to that. In the moment in which they're actually talking about this or wanting to not expose themselves, but feel vulnerable, because it can be such a secretive part of their life. They may not want to think about it or talk about it or share it.
Well, and I think that generally speaking, when people come in to seek help for something that is literally and figuratively in their head, right? Hyperacusis, anything hearing related, tinnitus, it's all in your head, literally, right? And people get very in their own way about it. They're in a heightened state. They're not their normal, necessarily best version of themselves in those states. I'm speaking from my own perspective when I'm answering those questionnaires too. You start questioning yourself on the questionnaires. So it's a consideration that we have, that there's a lot to go into the evaluation to make sure that we're making the best recommendations. So at this point, I'm wondering if we can talk about decreased sound tolerance and all of the different subcategories of that, because there's overlap with them and they are individual, definable conditions amongst themselves. Could you actually start with a kind of a brief explanation of just what is hyperacusis?
I feel like an important characterization of hyperacusis is that hyper part. When people can't tolerate those normal loudness levels, that suggests to me that they have hypersensitivity, hyperacusis.
Hyperacusis is used to identify a painful reaction to a sound, whereas someone else right next to them may not have that same reaction, this negative response to the sound.
There's a lot of discussion around kind of the finer points of, is it just loud sounds or normal sounds or soft sounds or whatever. But for me, that distinction comes when we have an aversion to sounds that are normally not considered loud. So sometimes people play sounds and ask a patient, "Oh, is that uncomfortably loud?" Right, and then they'll slowly increase it. Right. So that's one way that we kind of try to gauge if there's actual hyperacusis. A lot of times patients will come in and their chart for me will say hyperacusis, and I'll say, well, it said that you were sensitive to loud sounds or sensitive to sounds. And they go, yeah, well, fireworks, fire trucks driving by, ambulances, that kind of stuff. Well, for me, that's a different flavor of loudness intolerance. And actually, there's other things that clinically, I think, are likely going on, particularly like in folks with hearing loss. They might just have like what's called loudness recruitment, where their sensory cells just kind of don't fire correctly because they're degraded. Right? So to me, there are some important distinctions here. But some providers kind of use that umbrella term that have a bigger basket than I do.
Hyperacusis is interesting because it is about when sounds are loud, we have a reaction. That reaction can be defined differently, though. We can have a pain reaction, as Juan pointed out. We can also have annoyance or even a fear-based reaction. I want to get away from this because I'm worried about the outcome, but I'm not necessarily in pain yet. This is the flavor that a lot of people with tinnitus.
We're nodding emphatically, yeah.
Right. I would put myself in this boat too, of I'm worried about exposing myself to loud sounds, so I'm acting hyperacusic, but it's really just because I don't like my tinnitus ramping up. I'm speaking from my past self worries. So these are all versions of hyperacusis, and it's okay to kind of put them all under the same umbrella.
Yeah. I think for clinicians, I think the important thing is that some of these mechanisms are functionally different. And so when you describe that fear and avoidance, that phonophobia, sorry to jump the gun on it.
No, please bring in phonophobia.
Right? Phonophobia being that a pre-delay, It's like we think this is going to happen. And so we have that maybe uncontrolled fear, and then we have avoidant behaviors. And that can actually, when we see those avoidant behaviors, result in people overusing hearing protection.
Yeah.
And then becoming hyperacusic.
Which Vincent talked about, right?
Yeah.
In his episode.
Yeah. I would get super annoyed at everyday sounds and so sort of hyper focus on that and just get irritable about, what we all experience in daily life, whether it was like just the neighbor mowing the lawn or like I was in an apartment that there was a gym above the apartment and like people would like drop weights. And I was like super annoyed with that, even though it wasn't like damaging. It was just like annoying.
And I would also say that all of these, just like any response that we have, there's a spectrum. The average typical person has all of these, right? The difference is that they don't have them to a point where it interferes with their life. Right. So we all have phonophobia. When you hear certain sounds, you get scared. You should get scared when you hear certain sounds, a thump in the night in your house. That's a fear-based response to a sound. We should get a pain response to certain loud sounds. When an ambulance drives by, we all cover our ears. The problem is when it's interfering with your daily functions and interfering with your quality of life. Now it's hyperacusis. Now it's phonophobia, right?
Absolutely. That's that. And then we start calling that a disorder, right?
Right.
So that disorder is the overarching thing. We treat lots of hearing and balance disorders in our practice. Reduced sound tolerance kind of sits as one type of overarching disorder, and then we have all of our disorders within that: the hyperacusis, the misophonia, the diploacusis, the phonophobia. All that kind of all lives in there, right?
Yeah. At this point, I'm imagining that this is now one of those talk shows where they have a very long couch and they keep moving the guests down, and then we invite a new guest out. We've talked to hyperacusis. We've gone over the new movie that hyperacusis is in. Move down one seat. We've talked about phonophobia. Move down one seat. Now, Juan, can you introduce our last guest for the evening?
So misophonia is more of the adverse reaction, this negative reaction to a sound that isn't necessarily loud, but it almost is very excruciatingly loud and annoying and irritating to that individual. Some sounds could be like chewing gum, swallowing, squeaking from shoes. That's just extraordinarily loud.
And I think the key there is that it is a specific sound trigger that's causing the person with misophonia to have a very extreme reaction. The reaction that's classical, even though this isn't all of my patients with misophonia, is more of like a rage or anger reaction. Mm-hmm. So very different from the fear-based, get away from it reaction of loud sounds, or I'm intolerant, I'm going to cover my ears, it's painful, of hyperacusis. Instead, it's, I want to make that guy stop making that sound. It's a very anger, aggression-based reaction. Not always, but most of the cases are that way.
Yeah, I found that to largely be the case. Not only specific sounds, but sometimes even specific people.
Yep, absolutely. I've had people who are only annoyed about chewing sounds when it's their parent or when it's their spouse or when it's their sibling. We've had patients of any age complain about misophonia. Brendan, I remember you mentioning that you see a number of misophonia cases. What is your experience with misophonia in the clinic?
I see misophonia most commonly in pediatric patients. There's a lot of important dynamics to understand, I think, when it comes to diagnosing and spotting these various disorders. But sometimes it's sort of the outward expression of mental health disorders or things that can interfere with a child's development.
Yeah. The early onset is typically in early adolescence, like 8 to 13-ish.
Yeah, totally.
Yeah. And then in a lot of these kids, I mean, a lot's going on in your life when you're that age. A lot of development, a lot of hormones, a lot of social things, a lot of family cues. The adults that I see with misophonia, very often it's that it started then, and then it kind of, I don't want to say festered. It sat for a while as a socially okay thing for them to have these avoidances. And then as an adult, it very often presents as, there's probably a better way to say this, but essentially hermiting yourself, right? Removing yourself from these settings that you find to be anger-inducing or annoyance-inducing. For instance, I knew adults who they refuse to eat with other people in the same room. Why? Because they hate the sound of chewing. Why? And then if they think back to it, they go, actually, I've always hated that. And that I never sat and ate with my family, right, as a teenager because I couldn't stand the sound of chewing and forks clinking and things like that. So it can become more pervasive like that and go throughout somebody's life, but it really is more of a pediatrically focused thing.
Yeah, I agree.
Have you guys seen many adult cases with misophonia?
Not too many for me. Some people might get not confused, but they may mix up the terms if they read something online real quick, or if they're actually rather experiencing tinnitus, or if they have an active ear infection. So it's something else going on to what they think is happening. They'll think, oh, well, that happened to me once. I was irritated by the nail on the chalkboard sort of a thing. Okay, but is it something that's invasive to your life? Does it happen daily? How is it affecting you and your flow with life? And yeah, so I think clarifying is always important.
Mm-hmm. I agree with Juan. More often than not, to me, people who come in with the diagnosis from the referral says misophonia, it's often not quite right. Mm-hmm. But we've kind of been hinting at this all along, that there does tend to be a lot of overlap with all these various decreased sound tolerance disorders. But I think our role, we have this advantage in that we have the terminology to help patients understand what these disorders are. Mm-hmm. But I think also from our perspective, these differences do matter to me because they ultimately will dictate the management approaches, especially like who I refer to and what other professionals I bring into the conversation to make sure that I'm staying well within the bounds of what audiologists should be doing. And also like using great resources in your area, like getting to know folks in behavioral health and developmental peds and lots of other resources within various health systems, which is challenging these days, but definitely worth every effort. Every time I reach out to a new provider and say, hey, listen, I saw you referred this patient, primary care refers this patient for misophonia. What we found today was actually this. And I think it would be really good for this patient to first be managed with, this plan here in audiology, but also we need to see behavioral health. We need to see this specialist, that specialist, and really lean. And I would say 99% of the time when I send that note to primary care, they gladly sign off on whatever referral, however it has to work for you and your state and your license and all that good stuff. Primary care is always happy to get to the bottom of things.
And there's a lot of overlap with all of these conditions, all these auditory conditions, including tinnitus, hyperacusis, misophonia, phonophobia, with mental health conditions as well. We call it comorbidities, right? Although that sounds horrible. But these conditions overlap with compulsion disorders, anxiety, because they are all essentially circling back to the same thing, which is something in my environment or something internal to my body or to my experience of the world is causing me distress. Other people are hearing the same thing and maybe feeling the same thing, but I'm bothered by it. So what's going on with me? We all kind of perseverate on certain things or find certain things to be focused on, and finding your ears to be a thing that causes stress is a pretty common focal point of that. So getting, like you said, an individual to the proper mental health expert. So that brings me to my next thought, which is if you are not a clinician and you are a person, a human living in the world, we call them patients, but they think of themselves as people. What would we recommend for them? Who should they go see first if they're feeling like loud sounds are bothering them, fear or pain or whatever, or certain sounds are bothering them and interfering with their life?
Sometimes it's something as simple as something in your ear. They usually have a good referral resource and they have a means to follow up in what the next step could be. Because if everything seems okay with the auditory system, there's still something to figure out.
And to Brendan's point, the audiologists are usually the ones who are versed in the nuanced differences between all of these. I have heard a lot of patients finding their way to an evaluation because they read on the internet about misophonia for the first time and they said, that's what I have, even though it might not be. Or they heard about a condition called hyperacusis on the internet and they decided that that's something that they should look into because it kind of describes them. But if they end up at a provider who is not aware of the nuanced differences, they may, like you said, get labeled with any one of these. So it's nice to just start with audiology.
Yeah, I think it's also fair for us. We're all folks who are well versed in identifying and managing these conditions, but it is a specialty area in audiology. So I want patients to feel like, just know that, starting with any audiologist is great. And sometimes they may even say to themselves, you know what, I'm a great cochlear implant specialist, but I've got the person for you, who's really, they do this all the time. Right.
Good point.
This is a specialty area, just like kind of music audiology is a specialty area and pediatrics is a specialty area. It's okay to ask your provider for lots and lots of resources. But couldn't agree more that, even starting with primary care and going, I don't know what's going on with my ears. Could you send me to audiology? Most insurances are covering hearing tests, right? And that's where the conversation can start. And then kind of managing, well, where can we go? That's actually a thing that I enjoy in my practice is helping triage and working closely with primary care and other specialties to kind of pin down a path that the patient feels positive about, right? And that I also think can be effective, right? So engaging them in the process of deciding, well, would you do therapy?
Yeah.
Right? We know that cognitive behavioral therapy is one of the most studied and effective methods of managing tinnitus. But if I say to a tinnitus patient, are you ready to go to therapy? And they go, No, absolutely not. Then that's a non-starter, right? So we need to engage patients in what we feel is best for them, make all the best recommendations you can, kind of help them choose from that. Where do we go to next? What's the first thing we do? What's the next thing we do, right?
Yeah. And I think you make a really good point too that I failed to think about in prepping for this. There are tinnitus and hyperacusis clinics, specialists who have it on the shingle out front of their office that they want to see your case if it's complicated or if it's a major impact on your life. Medical centers, major medical centers are also a good starting point. I would throw out there that universities often have a lot more time. And really what it comes down to is we need a little bit more clinical time to work through some of these nuances. And if you go to a university center for that evaluation, they may have a little bit more clinical time and that kind of academic approach to let's get in there, let's figure it out. Not to say that private practices don't, but I think that's probably where I would start.
Couldn't agree more. Yeah.
Yeah.
Cool.
It's something that's there and something that's available and oftentimes accessible too.
Yeah. And we live in a world now where you can do telehealth. So if you are a musician, for instance, we talk about this all the time. We talk about music cares. You can hop on telehealth. This whole conversation, what did we say? The tools to assess this are mainly questionnaires and conversations. Hearing testing is great, obviously. So you may want to start with a local provider, but there are specialists who do telehealth for tinnitus, for hyperacusis, for misophonia. There's online support through that as well. All right, we're wrapping up this conversation about decreased sound tolerance. There's one more thing that I think is just kind of like in the current zeitgeist, right? That is the concept of decreased sound tolerance or oversensitivity to sounds and how that's connected to neurodivergence. Brendan, did you want to clarify a little bit of how we're thinking about that nowadays?
Yeah, when we see patients in the clinic demonstrating neuroatypical behavior or other kind of presentations, I think as audiologists, it's really important that we identify those conditions and cases, even when we're not sure, and find good ways to refer to the appropriate providers. So developmental pediatrics, for example, leaning on them. But again, when I go back to primary care and say, I don't see a whole lot of evidence of any kind of auditory dysfunction, but there's kind of this cluster of things. Diagnosing autism spectrum disorder is not within my scope of practice.
Right.
I'll be honest, a lot of times when those folks come to me, they already are carrying that diagnosis, and families just kind of want to understand better management strategies. And I think that's appropriate. But when we don't have that diagnosis, I think it's really, really important to, again, tap into those resources of people who do this thing for a living.
Now, are you talking more about school-age children who wear earmuffs when they go out into public, or are we talking more about young professionals who decide that they don't like the sound of loud bars anymore?
That first group, to me, the kids who are using headphones and earmuffs, this is kind of where we start to think about, well, why is there a reduced sound tolerance, or why is there aversive reactions? When we start to see, folks as we age being less tolerant of being in loud, noisy spaces, there's a handful of great kind of studies around that about some of the high frequency hearing loss things, and being able to process speech and noise and all those good things. And that's why, again, audiology as a resource, I think, is a real asset to all these different types of questions that other providers have and patients and families have about reduced tolerance for sounds that normally in our environment people would have no aversion to.
Yeah, I think that's a really nice way to wrapping that up. And there's a lot more nuance. I'm sure we could spend easily an hour talking about any one of these subcategories, but just to rehash what we talked about, because in the episode with Vincent, we just used the blanket term of hyperacusis. He used the term hyperacusis, and I fully support patients, guests, humans in the world using whatever term kind of resonates with them. But I like that we were able to go back through and discuss how that fits under the larger umbrella of decreased sound tolerance, and then talk about how there are nuanced subcategories of hyperacusis. And then we can branch out even into these ones that don't have to do with only loudness of sound, but actually specific sounds or specific reactions, such as misophonia and phonophobia. So that's a lot of terms. It's a lot of Latin sounding terms that are thrown out really, really quickly. But hopefully this office hours helps parse out those details and avoids us getting in the way of the good conversation and the journey of our guests when we're actually in the conversation with them.
Thanks, Brendan, for joining us.
Always a pleasure.
Let's do it again soon. If you have any questions about this topic specifically or about the show in general, feel free to reach out, because we are always interested in talking about whatever you are interested in talking about, as long as it's talking ears. Sorry, that's cheesy, but there you go.
That's a wrap.
Talking Ears is a production of Earmark Hearing Conservation and Philadelphia Musicians Clinic. The show is proudly made by humans, not by AI. This episode was produced by Juan Vasquez and Mary Kim, and myself, Frank Wordinger. The theme music is by Scott Hallam. Talking Ears really is a labor of love. We make it because we care about the topic, and because we want to celebrate sound and listening and hearing, and all the wonderful things that music does in our lives. The show was built on the premise that all ears and all people matter, and no musician or person should get injured while they're creating art and making the world a more beautiful place. If you've listened this far, it is not a stretch to assume that you actually enjoy this show. If you like what you hear and you want to support the show, the first thing that you can do, the biggest step that you can do, is go right over to Apple Podcasts or wherever you get your shows and leave us a review, a 5-star review. Say what your favorite episode was. It really helps other people find this show. Please share the show with your friends, with your coworkers, your HVAC person who comes over to check your AC that has been acting up in all this summer heat. Just let everyone know. There's no reason to keep it a secret from you. Thanks for listening.